Thank you, everyone, for joining us this afternoon, this morning, depending on where you're zooming in from. I'm Jason Resendez, President and CEO of the National Alliance for Caregiving. And today we're addressing one of the most pressing challenges facing healthcare delivery in America: the growing disconnect between our health system's reliance on family caregivers and our failure to systematically support them. Today's forum, our second annual forum, will explore opportunities to better integrate family caregivers into healthcare delivery through innovation and policy reform. We'll start by examining new data that shows this isn't just a future problem, it's happening now, with tens of millions of Americans engaged in ongoing complex care. Then we'll move from problem to solutions, showcasing work with our partners at the Coalition to Transform Advanced Care, CTAC, on how different payment models, from fee-for-service to accountable care organizations, can help us systematically incorporate caregiver support. We believe Medicare can and should play a bigger role in sparking caregiver innovation and support across the full spectrum of care. Finally, we'll dive deep into a transplant caregiving case study, showing both the gaps in current support and identifying opportunities available through OPTN modernization to include caregiver voices and perspectives to help shape and strengthen these efforts. You'll also learn about immediate advocacy opportunities to address the challenges that we'll discuss. And at the end of the presentations, you'll have an opportunity to ask questions. And throughout, you'll hear directly from policy experts and from a family caregiver about what this means on the ground. Because data alone can't capture the human reality of families struggling to navigate complex care without adequate support. Our goal today is to leave you both with the urgency of this challenge and with actionable ways for addressing it within your own systems and policy work. Next slide. Before we dive in, I want to share some background on the National Alliance for Caregiving. NAC has been at the forefront of caregiver advocacy for nearly 3 decades, since our founding in 1996. We're not just research leaders, we're system change agents working to fundamentally transform how society values and supports family caregivers. Our approach is three-pronged: rigorous research to build the evidence base, strategic advocacy to drive policy change, and narrative change to shift public perception and awareness of family caregivers. The logos you see here represent our membership network, spanning healthcare systems, pharmaceutical companies, technology firms, and advocacy groups, and patient advocacy and caregiving, because this isn't a niche issue. It's a healthcare imperative, a societal imperative that crosses all aspects of society. Next slide. NAC's work centers on 3 interconnected priorities that address the full spectrum of the caregiver reality. 1, we champion caregiver health and wellness. We can't ignore that caregivers themselves are experiencing health challenges. They're burning out, they're getting sick, and they're struggling with their mental health. We drive economic inclusion. Caregiving shouldn't force families into financial ruin. We're pushing for policies and programs that recognize and, most importantly, value the economic contributions of family caregivers. And we're fostering caregiver-friendly communities. This means everything from workplace policies to health systems that actually see, recognize, and support caregivers as essential partners in care. Next slide. And we do this work because we know that caregiving connects tens of millions of Americans. In fact, if I ask folks to raise your hand if you've been impacted by caregiving, I'm sure more than half of the folks in the Zoom room would do that. And I'm always shocked, but never surprised by the response to that question when I'm out and about giving this kind of talk. In just 1 decade, we've gone from 43 million family caregivers to 63 million family caregivers. That's nearly a 50% increase. To put this into perspective, 1 in 5 Americans is now a family caregiver for an aging loved one, someone living with a serious illness or with a disability. And that doesn't even touch on the many, many, many more millions of us who are providing childcare. This isn't a temporary trend. Demographic projections show this will only accelerate as the population ages and people live longer with chronic conditions. Next slide. Our health and wellness initiatives at NAC are designed to catalyze system change for families navigating complex care, leveraging our deep partnership network to amplify and accelerate policy and practice transformation. We focus on two interconnected approaches that work together to drive change. We lead complex care collaboratives. We're bringing together stakeholders from cancer care, transplant care, and other complex conditions to facilitate peer-to-peer learning and to develop insights that can be translated across care settings and conditions through policy and research. We elevate the caregiver voice. This goes far beyond collecting stories. We're systematically translating the lived experiences of family caregivers into actionable practice and policy recommendations that decision makers can implement. This includes our Portraits of Caregiving platform and our incubated project right now called Spillover Effects, which helps us understand not just who caregivers are, but how their well-being creates ripple effects throughout the entire care ecosystem, affecting patient outcomes, healthcare costs, and workforce stability. Now, let me show you what this research reveals about the current state of caregiver health and why urgent action is needed. Next slide. Our research reveals a health crisis hiding in plain sight for family caregivers. Looking at our caregiving in the US data, which was just released in partnership with AARP, we see alarming trends. Caregivers reporting fair or poor health jumped from 7 million in 2015 to 11 million in 2020 and 12 million in 2025. The emotional stress numbers are even more striking. 16 million family caregivers experienced emotional stress in 2015, growing to 19 million in 2020 and 24 million in 2025. What's particularly concerning is that emotional stress is affecting nearly 40% of all caregivers. This isn't just individual suffering, it's a systematic failure. This trend line shows both physical and mental health challenges are accelerating. Emotional stress has grown by 50% over this decade, while the population grew by about 46%. When caregivers break down, the entire care system breaks down with them. And they're not just family problems. These are healthcare delivery problems. And healthcare systems that don't address caregiver well-being are essentially undermining patient outcomes. Next slide. Now, this slide reveals perhaps the most concerning trend. Family caregivers are being asked to perform increasingly complex medical and nursing tasks without adequate preparation. 34 million family caregivers in 2025 were managing medical and nursing responsibilities, tasks that have historically been conducted by healthcare professionals in acute care settings. These aren't simple activities of daily living. We're talking about medication management, wound care, operating medical equipment, and monitoring complex conditions. The healthcare system has essentially shifted complex care to the home without shifting support systems needed to make that care sustainable. Next slide. And here's where the system failure becomes crystal clear. While there are 34 million family caregivers assisting with medical and nursing tasks, only 13 report receiving any kind of training for carrying out those roles and responsibilities. That means nearly 2/3 of caregivers managing complex care are doing so without preparation or support. That's a lot of YouTubing. This is unfair and unsustainable and represents a systematic problem that requires healthcare delivery model reform, not just individual interventions. And accelerating that reform couldn't come soon enough. Next slide. The push towards home-based care is accelerating, driven by both policy incentives and market forces. McKinsey projects that $265 billion worth of care services could shift from clinical settings to home-based settings by the end of 2025. This represents a 3 to 4 increase over current home-based spending. While this trend offers benefits, lower costs, patient preference, better outcomes in some cases, it fundamentally depends on family caregivers. This Washington Post headline captures the reality. Hospitals are increasingly expecting families to provide complex care at home. And without systematic caregiver support, this trend could lead to worse outcomes and health inequities. Next slide. Now, the scale of this shift toward home-based care has not gone unnoticed by advocates and policymakers. We're starting to see regulatory recognition that family caregiver support isn't optional, it's essential infrastructure. This timeline shows incremental but important momentum in policy recognition of family caregivers. We're seeing bipartisan acknowledgement that this isn't just a private family matter, but a healthcare system imperative. Key milestones include the establishment of a health risk assessment for caregivers, implementation of the caregiver training services through the Medicare physician fee schedule, and the introduction of the guide model. The guide model is particularly significant because it explicitly recognizes caregiver support as essential to patient outcomes in dementia care and shifts reimbursement policy to recognize and value that. Each of these policy advances represents evidence that the healthcare system is beginning to recognize what we've long known. You can't separate patient outcomes from caregiver well-being. However, these are still early steps, and we need this recognition to spread across all care contexts and delivery models, which will be a big focus of our conversation today. Next slide. At our Caregiver Nation Summit last year, we heard from Pavarthi Krishnan, a family caregiver in our network. Her words capture the essential paradox of our healthcare system. We depend so much on family caregivers, but we don't invest in sustaining them. Notice her key insight here. To keep them out of the hospital system, we need to sustain ourselves. This isn't just a caregiver asking for charity. They're identifying what the healthcare system needs to function effectively. When caregivers can't sustain themselves, patients end up back in expensive institutional care settings, and caregivers experience worse outcomes themselves. This quote encapsulates why caregiver support isn't a social service, it's healthcare infrastructure. And now to explore more the lived realities of the caregiver experience and to share NAC's most recent research on transplant caregiving, which offers a lens into many of the challenges I've highlighted today, I'm happy to introduce Melina Pinheiro, a family caregiver and senior manager with NAC's Health System Transformation Team. Over to you, Melina.
Thank you, Jason, so much. Hi, everyone. As Jason mentioned, my name is Melina Pinheiro, and I'm the Senior Manager of Health Programs at NAC. Before we begin, I actually want to see who's in a room. You should see a poll pop up. Let's take a few seconds to answer. If you don't see how you fit, the question is, which of the following best describes your connection to transplant caregiving? If none of the choices fit, please click other, and I'd love to see in the chat who's in the room. Oh, I can't see the poll. Well, I unfortunately cannot see the poll, but I would love to see the results afterwards. Well, for me, this isn't just professional. I'm a transplant caregiver, and I wanted to ground today's conversation with my caregiver story. Next slide, please. And next slide, please. One more. So I want to take some time to tell you about my mom. She was witty, charismatic, someone everyone immediately loved. And she just wasn't my mom, she was my best friend. And in 2016, our lives changed completely. My mom suddenly became ill, and I stepped into a role that I really did not understand, which was caregiving. And I honestly didn't acknowledge I was a caregiver until recently. Over the next few years, my mom's condition declined, and we had to learn how to navigate a fragmented healthcare system with very little guidance. By 2021, she was finally placed on the transplant list, and then that's when the intensity of caregiving really set in. From day one, my brother and I had to navigate enrolling her into Medicare and disability, and even with a financial navigator, it took multiple applications for her to finally be approved. And while that was all happening, my mom was also undergoing test after test to determine her eligibility. And there was no roadmap, no, like, she would keep asking, when is this over? I'm tired of doing so many tests. And we didn't know what to expect. Only after the evaluations were complete did we get a 2-hour education session, and it was all in English. And my mom's preferred language was Spanish. She understood English, she spoke it very well, but she wanted to receive the information in Spanish, in her native language. And it's something we communicated, and instead I had to translate everything, which it was a lot of work to do. And I was also managing my mom's fear, her stress, and her medical condition. The session that we received focused on clinical details. So nothing about how our lives was going to change. There is no explanation about coordinating appointments, managing medications, or emotionally supporting someone facing a transplant. After the education session, we met with a nutritionist. My mom, who was already exhausted, was given a long list of dietary restrictions and medication guidelines. And again, it was all in English. And I'll never, ever forget how overwhelmed my mom looked. If those materials had been offered in Spanish in a culturally familiar way with examples of what was related to her foods, it would have made a very difficult moment a little bit easier. But instead, I had to deal with that aftermath. Later that same day, we met with a social worker, and she asked if my mom had two caregivers, transportation, housing, but no one asked about us, her caregivers. We're required for the process, but no one checked in to see how our financial situation was, the emotional strain, or what we needed to stay afloat. And again, we were required for this process, but we weren't offered any type of support. And at that time, I was working full time. That meant rearranging my schedule, working nights, weekends, just trying to catch up because I didn't want to use my FMLA while my mom was going through all these processes to be able to use it during, the transplant process. So, many caregivers have to face this, and there's a impossible choice of do you miss work or do you miss care? And for me, missing care didn't even feel like an option. My mom's care team was often disjointed, and we had so many different doctors who had conflicting instructions. And I remember one point my mom was scheduled for a procedure that she had already completed. And if it wasn't for me being there pushing for clarity, then things could fall apart. My mom sadly passed away while she was still waiting for her transplant. And the day after she died, I got a call about an unpaid bill. A month later, another transplant center called about her eligibility. And these are just examples of how fragmented our system can be. Looking back, I know our journey could have been different with earlier proactive outreach, culturally responsive education, and even just a check-in. What do you need? And my reality, sadly, isn't unique. Our research confirms that transplant caregivers across the United States are facing these things. In fact, most transplant centers won't even list a patient for a transplant unless a caregiver is identified and confirmed. Yet, even though caregivers are a requirement, the system rarely prepares or supports them for that role. And that's why we launched the Transplant Caregiving Collaborative to better understand what support exists, where the gaps are, and how we can promote practice change and advocate for policies that truly recognize caregivers as part of the care team. Next slide, please. So in 2023, we released Transplant Caregiving in the US, a call for systems change. You can actually use that QR code to download the report, and there's also a resource tab where it has all the links of today's session. The study drew on a wide foundation, so there's a literature review, a panel of subject matter experts, focus groups with caregivers, and we did in-depth oral histories with caregivers as well. And the findings were clear. Caregivers face high stress, minimal preparation, little recognition, and serious financial strain. And there's also systemic gaps that are causing all of this. And there's things such as no consistent process for caregiver assessment or screening. There's poor coordination and follow-up across centers. There's inadequate financial and logistical support. There's a lack of formal caregiving training, and there's no standardized way to collect caregiver data. And importantly, caregivers from disadvantaged or diverse racial and socioeconomic backgrounds face even greater burdens. Next slide, please. So to build on that, we released a second report in 2024, Gaps and Opportunities, Family Caregivers in the U.S. Transplant Centers. So we surveyed 143 participants here from 114 unique transplant centers across the United States. And we received responses from directors at the transplant centers and support staff. So that's social workers, psychologists, nurses. And the survey focused on three key areas: caregiver assessments, service delivery, and education training. And some key findings, and again, I encourage you to download the report because there's actually a lot of findings in it, but I'm only going to review a few of them. Is that over 40% of transplant centers have no written process for assessing caregiver needs. Most transplant centers offer between 2 to 4 types of caregiver programs, and 30% offer no programs whatsoever. So a lot of this is dependent on where you live, if you have a transplant center that's offering any type of programming. And then among the 58% that did provide education, the timing and content varied widely with no consistency or standards. And again, this all shows that not only are programs limited, but also the delivery depends on where you are receiving care. Next slide, please. So we're excited to announce our newest report, the Family Caregiver Gap, Disparities and Missed Opportunities in Support Services Across the United States. And it draws directly on the survey data from our previous report from last year, 2024. But this one allowed us to dig a little deeper. So we're not just reviewing whether services exist, we're also seeing how they're being delivered, who's using these services, and who gets left behind. The report is divided into 5 key areas: delivery, how are the services being delivered; utilization, how are the caregivers using those programs; drivers, what drives support and when; barriers, what obstacles are certain centers facing; and disparities, who is being left behind. Next slide, please. So let's start with how the services are being delivered. What we found was that there is a heavy reliance on outsourcing. So 2/3 of centers outsource financial counseling, more than half outsource the screening, and even medical education is most often referred out offsite. So the problem with outsourcing is that it tends to create delays and barriers. If a caregiver can't take off work, if they can't travel, or if they're never followed up with, then that referral is a closed door. And it leaves that caregiver unprepared, which can potentially affect patient care. And additionally, there's an all or nothing pattern, with some centers having an array of support, while others have very limited or no access to services. Next slide, please. So how are caregivers using services? When programs are available, about 60% of caregivers use them. Um, as you can see on the graph, group psychosocial programs and peer mentoring are the most used programs, and it suggests that caregivers desire that social support, that emotional connection with those shared experiences. On the other hand, programs targeting social determinants of health, such as material resources, referral, or youth-focused support are not as frequently used. And this takes us back to the outsourcing point. It leaves the most vulnerable caregivers to face unmet needs. Next slide, please. So what actually drives support and when does it happen? We found that caregiver support is largely reactive, with only 3% of centers regularly assessing caregiver needs. And I'll say that again, only 3% of centers are regularly assessing caregiver needs, meaning that a lot of these interventions are happening at key milestones, with 49% occurring when a patient's placed on the wait list, and then 43% with a dry run, and then 38% during a crisis. So that's like hospitalization. And this leaves caregivers to manage a lot of this on their own until something really big happens. And too often, program access occurs when caregivers ask for help. So they're raising their hand, they're saying, hello, I really need help. And that self-advocacy piece is adding an additional burden to already stressed out and burdened caregiver. Next slide, please. So what barriers are transplant caregivers facing? Centers cited 3 main barriers, and the highest one really surprised us, and it is limited awareness of caregiver needs. 48%ers are not aware that caregivers have needs, and if they're not being recognized as part of the care team, then the programs and resources won't follow. The other barriers included financial constraint at 43%, and then staffing shortages at 42%. Next slide, please. The last thing we explored in this report was disparities, and we found that caregivers from marginalized backgrounds are systemically the least likely to receive support. So centers serving Black or African American patients are offered less programs, so just 21 to 28% compared to 33 at the overall ratio. Low income centers were the least likely to offer financial counseling at only 22%. And then youth tend to be overlooked with only 18% of centers having a program, and then that dropping down to 11% for low income centers. So the families carrying the heaviest burdens are the least likely to get help. Next slide, please. I want to leave you with these words. The hardest part for me is that you really do become a nurse or a tech in a way. He had a port and I had to deal with the dosage of medication, and it was not easy. This is Nancy, who was a stem cell transplant caregiver for her husband, and she had to do a lot of the medical tasks that was discussed. Family caregivers are essential members of the transplant team, but until we recognize and support them with the training, resources, and consistent outreach, the system will continue to fall short. The challenge is that our current care models often treat the patient as an individual and not as part of the dyad. This means caregiver needs are often overlooked until a crisis occurs. We really need to move from a reactive model to where we wait for a crisis to occur to a proactive model that routinely screens caregivers and connects them to the support from the very start. Next slide, please. I'm excited to introduce our next speaker, Hope Glassberg. She's from CTAC, and she's going to be sharing opportunities that are available to integrate caregivers into healthcare systems using Medicare kidney care choice models as an example. Welcome, Hope.
Thank you so much, Melina, and thank you for sharing your story. And unfortunately, exemplative of the challenges that so many caregivers face. As Melina mentioned, I'm Hope Glassberg. I'm the president of Decipher Health Strategies, and I'm also senior policy advisor to the Coalition to Transform Advanced Care, or CTAC. Many of us experience this issue professionally, personally, and everything in between. And unfortunately, I know many of us have either had the experience or seen scenarios where we may be visiting a loved one in a hospital or a health system, and we're described as visitors, even though, you all may be the ones managing medications, coordinating appointments, providing daily care. I think many of the folks assembled here today appreciate that family caregivers are more than just visitors at a bedside, especially when we're talking about home-based care, but are really essential partners in care delivery and design. Unfortunately, as has been discussed, many of our health systems treat caregivers as peripheral, invisible, or otherwise. And so today we really want to turn that work on its head through work that CTAC and NAC have been leading together. So we can move to the next slide. Just to tell you all very briefly about CTAC. CTAC is an organization that brings together over 200 entities nationally, spanning health systems, payers, community groups, and policymakers, all with the same goal of improving care for people with serious illness and their families. We know that caregiving is important in many instances, but especially when focused on serious illness or end-of-life care, integrating caregivers is especially critical and often especially complex given multifaceted needs. And I'm with Decipher Health Strategies, which is a healthcare consulting firm in the policy space, and I've been working with CTAC over the past few years on a number of strategies. Next slide. We are so excited to share with you all today that CTAC and NAC have been collaborating on a forthcoming report that we'll be releasing the week of September 8th. So mark your calendars, stay tuned. We'll make sure that folks on the webinar today receive this resource. This report, which we want to thank CTAC and NAC, both want to thank very much the ELIA Institute for their generous support and thought leadership around the development of this report. And this brief report sets forth a national action plan for integrating caregivers more fully into current healthcare care models and payment design. It draws on policy analysis, real-world examples, caregiver voices, all of which are absolutely critical in shaping the recommendations. And our goal is to assist everyone in moving from, kind of having this theoretical discussion to making sure that we have more models like what Jason flagged at the beginning around guide, where caregivers are really acknowledged in policy design, payment design, as we move forward together. Next slide. So just commenting that we all know, I think many of us that work in the healthcare field or are receiving healthcare services have an impression that payment drives behavior. So if we want caregivers, as I know believe all of us on the Zoom today do, to be a part, recognized as a part of the care team, we need to ensure that policymakers are thinking about how to design healthcare payment models that incentivize, recognize, and support the hard work that is doing the caregiving that many of us do or want to support through our work. In the forthcoming publication, to break this down a little bit, we identify four key types of healthcare payment model structures where you all might want to think about raising your voices to ensure that health caregivers are included in the conversation. So we have fee-for-service models, like some of the Medicare physician fee schedule items that, sort of at the end of Jason's timeline when we were talking about caregiver training payment codes and the like. We also have what we call accountable care organizations, which are models where we have networks of providers that are incentivized to collaborate and to work as a collective to improve care for populations, enhance quality, and drive down costs. A couple of examples are linked here, like the Medicare Shared Savings programs. These kinds of programs are intended to serve broad populations and defer to clinical and practical expertise to focus in on individuals who need care at the right place at the right time. Moving to the right-hand side of this slide, we also have specialty care models that are not necessarily serving a very broad population, but are serving a very specific, clinically defined or provider-driven kind of a model here. So these are some examples here, and we're going to be talking at greater length in just a moment about kidney care choices as one example, but you can see a few others here, some of which have come out of a part of federal government called the CMS Innovation Center, which is tasked with testing new payment and care delivery models. They've launched kidney care choices, as well as oncology care models focused on cancer care, and transforming episode accountability models, which are focused on different types of procedures often taking place during an inpatient stay. We also know, lastly, at the bottom right-hand side, that there's a lot of space and room and criticality in focusing on Medicare Advantage health plan-oriented strategies, and there's levers there as well to think about how we can ensure that caregivers are included in Medicare Advantage. So this slide, and as you'll see in the publication forthcoming, is really meant to offer to all of you a bit of a taxonomy for breaking down in a somewhat more straightforward way different kinds of healthcare payment and model structures. Next slide. So great, we've got these, four categories of payment model type, but where do we start when thinking about advocating, supporting, and ensuring that caregivers are meaningfully included in each of those kinds of care models? So here is the framework that we've come up with, and this is the framework, and then we're gonna walk through a specific example in kidney care choices to show you what it could look like. So first and foremost, we want to ensure that across a wide variety of models, that caregivers are systematically identified. Even before we get to a health risk assessment, let's ensure that these care models are structured in a way where caregiver relationships are surfaced early on in the process of engaging individuals in care. We also know that skill building, the slides that Melina was showing about uptake of different kinds of support. We know that skill building is not always available easily, but it is extremely important. I was really struck by that last slide with the caregiver who was mentioning that she's become a nurse tech of sorts. So ensuring that there are structured modules or other ways of ensuring that folks who have not made healthcare necessarily their profession are armed with the skills and supports to be effective caregivers is a really important part of the design process. Then, of course, there's the actual, kind of programs and interventions themselves. And that means meaningfully including caregivers. We've titled our report Not Just Visitors, but really including caregivers in care planning, in ongoing care decisions, in thinking about what next steps are in managing transitions of care to ensure that they're not just peripherally included, but are really a meaningful part of the care team. And then, of course, we also want to think about quality. A lot of the models on the prior slide have all sorts of quality metrics associated with the person who may be receiving, say, oncology care, how their chronic condition may be managed. But we also want to make sure that we're systematically assessing how caregivers are supported and thinking about the quality of their supports and care. Are they actually using services that are available to them? And if not, why? And then when they are using such services, how does that impact their stress, capacity, and well-being? So let's move to the next slide and run this through an example just to show you what this might look like in practice. So here's an example with Kidney Care Choices, which is a model that comes out of the Center for Medicare and Medicaid Services Innovation Center, the CMS Innovation Center, which, as mentioned, is a part of the Federal Health and Human Services Department that focuses on testing new models of payment and care. So this is meant for folks who are enrolled in Medicare who are facing late stage chronic kidney disease or end stage renal disease. It invites a variety of provider entities to collaborate together to create what they call KCEs, or kidney contracting entities. So these are, nephrology practices, transplant providers, dialysis facilities, maybe some of the organizations where you all work, maybe some of you are participating in this program. The idea is that these participating entities have created an ecosystem of providers to support care for the individuals I mentioned just previously. So the focus is on improving care through delayed dialysis where possible, increasing transplant rates, promoting care at home when feasible. And of course, with many of the models on the slide with the quadrant, the goal is better care coordination and less fragmentation and more person-centered care. In terms of the payment structure, it's essentially payment as usual. However, there's an opportunity for enhanced kind of a bonus type structure if quality and cost metrics are met. It was launched a number of years ago, and it's meant to end at the end of next year. So let's go to the next slide. This is the final one where we'll talk about. So we just talked about those 4 design features. So if we were all to pick up the phone and call the CMS Innovation Center, what are some of the things that we'd want to think about vis-a-vis caregiver incorporation into this model? Many of us who care about these issues have been following with great interest the guide model that Jason mentioned at the outset. We want to see that kind of meaningful acknowledgement and incorporation across all kinds of care models. But for KCC specifically, identification. So as mentioned, it's critical to have an approach whereby caregivers are identified upfront. We suggest that the KCC model or programs like it required structured care planning, like those health risk assessments or other strategies to identify caregivers and catalog their needs. Skill building. So while KCE entities are required to specify in the application process some of the ways in which caregivers are meant to be supported, there's no real specifics on exactly how they can or should be trained. We would ideally like to see much more structured education and support for caregivers baked into the model, similar to what we've seen in Guide. Program design. Again, a bit open-ended in the KCC application process, where caregivers are noted, but it's not really directive in terms of how they're engaged ongoing. We want to see, we've been talking about, Melina was mentioning dyads. We want to see dyads. We want to see them be connected to respite services, to reimbursements where possible, and also non-monetary incentives, transportation support, other types of things that help ensure that caregivers can meaningfully be engaged in ongoing supports for their loved one. And lastly, quality. Here, we don't really see caregiver burden or engagement measures explicitly mentioned in this model. We'd like to change that. We'd like to see an impact of caregiver support and engagement as a part of a core set of outcome metrics associated with the model. So this is just meant to give everyone a little bit of food for thought, and you'll see more in the forthcoming report about how to take some of these design features and consider how they might apply to caregiver models that you're either participating in or wish to participate in. So in closing, caregivers sustain our health system every day, and if we want these kinds of models to succeed, we need to move them to the center, and excited to continue the conversation with you all about this. So with that, I'm delighted to turn it over to Yadira Montoya, who's the programs director at NAC.
Great, thank you, Hope. Next slide, please. Okay. So we're going to shift gears a bit, and I am going to discuss advocacy opportunities to uplift family caregivers within the current transplant system reform efforts. So again, within using transplant care as an example. And next slide. And a brief disclaimer, my portion is not meant to be a comprehensive overview of the organ procurement and transplantation network modernization initiative, but rather a quick overview to set the stage for the advocacy opportunity I will be discussing and encouraging you all to take. So the OPTN Modernization Initiative was launched by HRSA to improve the U.S. organ donation and transplant system in 2023. The initiative centers on 5 key areas: technology, upgrading outdated IT systems to improve organ matching and allocation and the allocation system. 2, data transparency, increasing access to high quality, real-time data for patients, clinicians, and researchers to make informed decisions and to better measure performance. Governance, reforming the structure and oversight of the OPTN Board of Directors to increase its independence and accountability. Its operations, improving the day-to-day operations of the network, including organ transportation, member support, and compliance monitoring. And lastly, quality improvement and innovation, promoting a culture of continuous improvement across the system to increase transplant rates and improve patient outcomes. And it is also important to mention that these efforts are taking place against the backdrop of many heated conversations and issues within the transplant system outlined here on the slide. Next slide, please. If the ultimate goal of the OPTN Modernization Initiative is to create a more equitable, efficient, and transparent system, we need to not only include caregivers in the conversation, but in the decision making. In this slide, you can see that NAC's research on this topic of transplant caregiving really overlaps with what patients and families have shared with HRSA as part of their outreach efforts on the modernization initiative. And I should also note that this information comes from HRSA and Dr. Sumanair, who presented at last year's Transplant Forum. And what I want to call out is that patients, caregivers, and families have consistently identified the need for better support and education, resources in education, finances, and mental health. What we're adding to this dialogue is that the well-being of the caregiver is not an extra consideration, but rather a foundational element for a successful organ transplant. If caregivers are stressed, unsupported, and experiencing burnout, it directly jeopardizes patients' health. And we believe that by supporting caregivers, we are strengthening the entire transplant ecosystem. Next slide. So last year, as part of the reports that Melina has mentioned, we issued 6 recommendations on how transplant centers can better support family caregivers. For this presentation, we have mapped those recommendations to align with the national dialogue about the modernization initiative. As you can see, our first recommendation calls for standardized screening process. This would reduce bias and improve equity by screening for caregivers and their needs early during the waitlist period. By improving communication and evaluation process to include caregivers from the start, we align with OPTN's goal of a more fair and transparent system. Our second recommendation calls for a standardized process to store and collect caregiver information. This speaks to what Hope mentioned as well, that we need to identify family caregivers as they enter and interact with the healthcare system. Collecting and storing this information will help with care coordination, improve continuity of care, and provide a basis for research, again, directly supporting OPTN's data-driven and quality improvement goals. Third, we recommend having a dedicated caregiver to help coordinate with the transplant team. This same person can help address the concerns around transparency of information in terms of eligibility criteria for candidates, the evaluation process, and the organ offer process as well. Next slide. Our fourth recommendation is about ensuring support for caregivers by creating comprehensive standardized programs. These programs would be evidence-based and run continuously throughout the entire transplant journey. I didn't get into the details, but the earlier slide that had the family in the middle talked about the need for support, particularly post-transplant. And so I want to stress the entire transplant journey process. This aligns with OPTN's focus on improving data collection and quality metrics at transplant centers and making sure that this data is reported through existing government programs like Medicare, Medicaid, and to ensure accountability and data improvement. Our fifth recommendation calls for additional research to better understand the diverse needs of transplant caregivers and address existing health inequities. While this specific recommendation might be considered outside the scope of the current OPTN initiative, it very much touches on the longstanding issues of inequity for non-white transplant candidates and those of lower socioeconomic status. And finally, our sixth recommendation promotes the widespread adoption of Medicare training services billing codes. By using these codes, transplant centers can better access funding to support essential training for caregivers, or I should say, to be reimbursed for the services that they would be maybe providing for caregivers. And this effort also promotes alignment across agencies, including CMS, to create a more integrated and a financial support system for caregiver support. Next slide. So to conclude, I encourage all of you to join our efforts in raising awareness about the critical role and contributions of family caregivers within the ongoing transplant reform efforts. We created this short handout on the implications and opportunities within the OPTN Modernization Initiative on family caregivers. The handout lists different opportunities to engage with the initiative, but today I want to highlight one of those. And it is that HRSA has an ongoing call for public comments around the modernization initiative. We have created some template language for you all to use as a starting point about, again, the role and the contributions of family caregivers and their direct impact into patient outcomes. I should also mention that the summer 2025 OPTN public comments is now open through October 1st. Those are listed in the handout, but not on my slide, but I believe that the link was shared. And so with that, I will conclude my presentation and launch a poll about really interested in having a dialogue about with the rest of our panelists, but also hearing from you all about what are you taking away from today's learnings and information shared. So while I see that the poll has launched, so I'll wait for everyone about a minute and then begin the Q&A session. Great. And for the Q&As, I'm not able to see the results. However, we can jump right into thank you. They just appeared. And so thank you all for participating. I see here that the largest percentage of you all are going to apply these learnings in another healthcare area outside of transplant care. Thank you. And share insights with your organization. Awesome, great. So let's go into the Q&A portion, and we're gonna get started. You can submit a question in the Q&A box, but we're gonna get started with some of the questions that you all have submitted during the pre-registration period. So I'll start with those. And the first question comes for you, Jason, or Hope. And can you share your thoughts on the impact of caregiving thanks to the big, beautiful bill?
Yeah, so we anticipate many ripple effects from the One Big Beautiful Bill, HR 1, particularly within the Medicaid program that'll have ripple effects to other programs, including potentially the Medicare program. I think NAC, we're most concerned, have been engaging in this area on kind of two fronts. One, according to Caregiving in the US 2025, there are over 8 million family caregivers who rely on Medicaid for their own healthcare coverage. So as we think about potential loss of resources to states in the Medicaid program, that healthcare coverage is at risk. So that's something that we continue to monitor, ensure that family caregivers can access the healthcare coverage that they need. Second is as states have potentially fewer dollars, Medicaid dollars, they'll be making hard choices about what optional services to offer through the Medicaid program. And one of those optional services that historically, when states have fewer resources, that they cut first are home and community-based services. Those home and community-based services are really essential to making caregiving sustainable. So things like transportation, training, meal support, in-home health support through the Medicaid program, a direct payment in some instances through consumer direction. Those are all tied up in home and community-based services. So we are very mindful of looking at how those services will be impacted as this rolls out over time. And then finally, I would say are work requirements, right? These the part of the realities that we'll be facing and states will be facing are much more stringent work requirements and eligibility checks throughout the year. And as we've heard today, one of the realities, the hallmarks of caregiving today is administrative hardship and burden. Whether that's managing and navigating insurance coverage, whether that's navigating medication management, appointments, you name it. Stricter work requirements and paperwork associated work requirements will add a layer on top of that we anticipate impacting the family caregiver. So there are many ways that caregivers will be impacted potentially that we're working to understand and mitigate, and states do have a hard road ahead. And so we'll see, but we'll be thinking and working with partners to address these impacts. I don't know, Hope, over to you. You have any additional thoughts?
I would add that you covered it, but I'd add maybe two additional things to consider. One is in my remarks, and I know, Jason, you touched on some of this as well. Much of HR1 is focusing on Medicaid changes, insurance coverage. But the CMS Innovation Center, which is not the totality of what we're all focused on, but it is a place to test new payment and design models, specifically often focused on Medicare fee-for-service, continues its work. They continue to put new models out. They continue, at least in the models that they've rolled out thus far, to focus often on specialty care. So I would encourage continue to raise your voices more like Guide or Guide Plus as new models come out. And I don't anticipate that to change, notwithstanding HR1. I think the other piece too is, it's like never waste a crisis kind of a thing with cost pressures that are Medicaid is feeling acutely, and provider shortages that we've been seeing in the healthcare sector even before all of that. To me, that underscores even more the criticality of family caregiving as a part of our healthcare ecosystem. So I honestly think it sheds new light in a way on the importance of family caregiving as states are figuring out their way through these fiscal pressures. So I think now more than ever is the time to really double down and emphasize the importance of formally engaging family caregivers in these caregiver and payment models.
Great. Thank you. Thank you, Jason and Hope. We did get a question from the audience, and it's from Desi. She says, I was a caregiver for 16 years for my mom who could not talk, walk, or etc. Except for her Social Security payments and Medicare, we got no support from the government. Is there anything that's really going to help people in my previous situation if one is not on Medicaid? And I think, Jason, perhaps you can chime in on this one.
Sure. So this is an area that is really ripe for innovation in terms of direct financial support for family caregivers. and thinking about, well, what are the different forms that can take? The dominant form right now is through Medicaid and through consumer directed services, which is really critical because of a lack of or the shortage of direct care workers in this country. And so folks having the ability to be able to retain support and being able to choose, well, who should provide that support. In a lot of cases, folks want that to be a family member, and that family member should be eligible for compensation for that support provided. And so that is the predominant way. There are other programs though, and so it's hard to navigate without knowing the specific circumstances, but there are instances where the VA, the Veterans Administration, has similar programs. There are some payers that are testing these programs as part of their benefit structures. I hope mentioned Medicare Advantage. So it's important to understand through your insurance what programs might exist. And then there are opportunities through the Medicare program even to take it to engage in these kinds of programs. So there are two resources that I'd recommend you check out. One is called AIDLY, AIDLY, and we'll have my team make sure I'm spelling that correctly and add it in the chat. But it is a innovative service that helps you to navigate what programs you might be eligible for in your state, whether that's a tax credit or direct payment program. That's a great resource. And then second is RubyWell to help you understand whether or not you might be eligible through the Medicare program to receive some form of payment as part of your care team support. Those are just two. There's many other resources, but those are the two that come to mind.
Thank you, Jason. And we have time for one more question, and that is for you, Melina. There was also a lot of chatter or activity in the chat about caregiver resources, but can you share a little bit more about what caregiver resources are available?
Yeah, definitely. So, for transplant care, there's actually a wonderful toolkit that was created by the American Society of Transplantation, and it provides an overview of the journey for transplant caregivers, their responsibilities, the legal and financial considerations, self-care, the quality of life aspect, the relationship dynamics between patient and caregivers, which is something that you don't realize you're going through until you're in that moment. And it also provides organ specific information. And I'll actually drop the link in the chat, but it's a wonderful resource that's pretty comprehensive. Oh, you're muted.
You're still muted, Jadira.
Thank you. With that wraps up our Q&A session. I want to share our last slide. I want to thank all of our panelists. Want to thank all of you, of course, for joining today's forum and this important conversation. And I would be remiss if I didn't thank our sponsors, Sanofi and Takeda. So with that, thank you all so much. We'll be sharing the information, the slide deck, and the resources that were mentioned by all of us via email. Have a great one, you all.